This study aims to describe our experience and management of traumatic cervical A spinal cord injury patients. In particular, we would like to investigate the conversion rates of these patients in our unit. This is a retrospective study based on the National Spinal Injuries Unit Patient Database over an 11-year period. We have identified 123 patients who sustained a traumatic cervical cord injury with an initial Asia A grade on admission. Functional outcomes were measured on discharge. This includes motor scores and functional independence measure scores. We have a total of 123 patients in this cohort. The average age was 54.8 years, with a significant proportion above 60. Majority were male, and most injuries were secondary to falls, followed by road traffic accidents. Significant proportion of these injuries were in the mid-cervical spine, as shown in the graph. Majority of the patients were managed conservatively. The average length of stay was 200 days, with a 30-day mortality of 7.3%. In terms of conversion rates, majority had no clinical improvement on discharge. The conversion rate of Asia A traumatic cervical cord injury in our unit was 17.1%, regardless of treatment modality. As represented on the diagram on the right, we have 5 patients who converted from A to B, 11 who converted from A to C, and 5 who converted from A to D. In terms of functional outcomes, there was significant improvement in motor scores and functional independence measure scores on discharge. When comparing surgical versus conservative management, there was no significant difference in conversion rates. This was 21.3% in the surgical cohort versus 14.5% in the conservative cohort. However, we noticed a significantly greater FIM improvement in patients who underwent surgery. In summary, our overall conversion rate of 17.1% is much lower than the international average. However, there is significant improvement in motor and FIM scores on discharge. We have also demonstrated that there is no significant difference in conversion rates between surgical and conservative management. Several factors could explain our lower conversion rates. Most importantly, time to surgery is likely to have a significant role. Many studies have shown that early surgery within 24 hours of injury correlates to better conversion rates. In our unit, this usually takes place after 48 hours of injury. Interestingly, our conversion rate among surgical patients is comparable to that of late surgery patients in literature. Patient demographics may also play a role. The Glasgow effect, an older population, and comorbidities may also impact on conversion rates. Also, very rarely, some patients may demonstrate late clinical improvement after 24 to 30 months post-injury, and this data will not be reflected in our study. Finally, medical and rehab strategies may play a role, but we do not have sufficient data at present. Clinical implications of this study includes exploring implementation of early decompressive surgery in the unit. It would also be interesting to review changes in conversion rate data after implementing this change. Our findings also provide us with a better understanding of recovery patterns, which has an impact on treatment goals and managing expectations of the patient and their families. Here's a list of the key references used in this study. And with that, thank you very much for your kind attention. I'll be happy to take any questions.
Thank you, Amanda. There are a couple of questions popping up, so we will go through them. I'm just checking. Okay, so a question from Edward Seal. What is the Glasgow effect? Can you hear me, Amanda?
Hi, can you hear me?
Yeah. Thank you.
Right. So the Glasgow effect is a phenomena whereby the people in Glasgow have lower health. It's a phenomena where the people in Glasgow experience lower expectancy rates and they have more complex health conditions. It's postulated to be due to a combination of factors, including biopsychosocial factors. And there is also complex interactions between socioeconomic deprivation and health outcomes. So naturally, if the patient cohort is within Glasgow, we feel that there might also be a role in affecting the outcomes in terms of our conversion rates.
Okay, we've got another question. Are you able to say why of the 17 conversion patients were different, i.e. mode of injury, hemorrhage in the cord, on MRI, etc.?
I'm afraid, like in terms of the factors mentioned, like hemorrhage of the cord and MRI, I do not have access to the data in detail. But the reasons that we would think of the lower conversion rate in this cohort were, as mentioned in the last slide. So there will be several factors such as time to surgery, and also the population cohort itself. It's not the most healthiest of cohorts, and there could be other reasons in play, such as the rehab strategies and medical strategies that we do not have enough data to make a conclusion on. So I'm afraid, like in terms of the factors mentioned, such as mode of injury and cord hemorrhage, I'm not able to adequately attribute that to the reason of lower conversion rates in this cohort.
Okay, thank you. I'm afraid I will move on to the next presentation. Thank you very much for an excellent and succinct presentation.
Thank you.
So our next speaker is Mr. Manish Desai, and he's going to present on polytrauma with spinal cord injury, challenges and scope for doing things differently. Play, please.
Thank you very much for inviting me to present my audit and service analysis at BritSpine 2021 on polytrauma with spinal cord injury. Is there a scope for doing things differently? We admit traumatic and non-traumatic spinal cord injuries at London Spinal Cord Injury Center, and we have found that there is some additional complexity and challenges during the rehabilitation of this group of patients. But is there any evidence on this? So there is no guidance on how further specialist spinal and polytrauma and cognitive rehabilitation with follow-up surgical care should take place when patients are transferred to the specialist unit. Polytrauma with spinal cord injury patients are present with unique challenges to clinicians, as I would discuss further. We analyzed outcomes of 85 traumatic spinal cord injury patients over 2 years from January 2016 to December 2017. We compared outcomes of monotrauma versus polytrauma with spinal cord injury. 39% of the patients presented with monotrauma and 61% patients presented with polytrauma and spinal cord injury. Out of them, 73% were male and mean age was around 40 years. It is interesting to know that there was slight increase in the timing to go to the theater for polytrauma patients with spinal injuries, but there was significant increased length of stay in the ITU with polytrauma and spinal injuries. There was no significant difference between length of stay while waiting to come to rehabilitation unit and in the rehabilitation unit for patients in both groups, monotrauma and spinal trauma. You can see that the maximum number of patients had chest injuries followed by upper limb, lower limb, pelvic and abdominal injuries. The interesting thing to know was that there was no clear documentation in handover and transfer care records about mobilization of limb injuries and also how much to weight bear and what kind of precautions to take for multiple wounds. You can see the brain injury, there was discrepancy. There were 52 polytrauma patients with spinal cord injury. Out of them, 34 patients had traumatic brain injury. 26 had confirmed TBI on radiological evidence, while rest of the patient had clinical presentation. 18 patients out of them have impaired Montreal Cognitive Assessment, which affected their participation in intensive rehab program offered at our unit. This also led the team to get frustrated because patients were very slow in participating in carrying over rehabilitation protocols, and hence they require a lot of psychological and psychiatric input throughout the rehab period. You can see the discharge arrangements. Patients with polytrauma required going to interim placements rather than directly going home, and some of them required care homes as well. I would illustrate a case example and challenges faced in a typical polytrauma patient who was a 33-year-old male, a building construction worker, fell from height and sustained injuries to abdomen, chest, limbs, spine, and brain. He had bifrontal craniotomy, dural repair. He had lumbar spine stabilization. He had spanning external fixator for the left open fracture of lower end tibia and open reduction fixation of the ankle on the right side. On admission to the unit, you can see that this patient didn't have proper handover, that who is going to look after the bone transport protocols. We didn't have even equipment to do those things. We didn't have clear instruction. We could not contact the surgeon involved in this procedure. There was a poor instruction about therapy input and mobilization, which limb to bear weight, how much. And there was marked psychiatric presentation as well in this group, in this patient, because he had significant traumatic brain injury. It was difficult to get him through spinal cord injury education, and we didn't know where to send for traumatic brain injury follow-up. So this is a classical example of patients having problems with polytrauma and spinal cord injury. Summarizing our audit is that these patients do require longer time to undergo spinal surgery, and ITU, length of admission, remains longer than monotrauma patients. Along with them, they have got problems with wound management, and multiple surgical teams are involved. It is difficult to find out exact protocols from every unit. Significant psychiatric and cognitive issues along with traumatic brain injury presentations, which makes them difficult.
Okay, it just feels that it got itself cut off right towards the end.
Thank you very much for inviting me to present we didn't know where to send for traumatic brain injury follow-up. So this is a classical example of patient.
Can we let Mr. Desai in, please, into the video box?
Yes, just requesting now.
Hello?
Hello, Manish, can you hear?
Yeah, I can hear you.
Did your presentation get cut off right towards the end?
Well, slide edited to the right hand because to make it 5 minutes, it looks like.
Ah, right, okay.
That was the last slide.
Yeah. Okay, that was the last slide, okay. Yeah. Thank you very much. I haven't seen any questions popping up, but if I'm allowed, can I ask you a question?
Yeah.
It's, you mentioned the lack of handover regarding ongoing management of various injuries. So how do you think this could be addressed?
So we have developed a protocol now, a A4 size paper. So our outreach team fills in the information that, like, who is the upper limb surgeon, who is the lower limb surgeon, who is the pelvic surgeon, who is the neurosurgeon, the trauma nurse specialist contact details. So they bring those details in when the patients are registered for admission. So on admission, then we can contact those teams directly, because previously it was all over the place. Because in a typical patient like this, more than 6 teams were involved. And you know how the trauma system works in a busy Royal London St. George's. It is just difficult to approach anyone in the trauma team because they are always busy with multiple trauma patients and those things. So that protocol has improved the practice, yeah.
Okay. I think I've seen something on the chat from Swarup Shanbag. She has mentioned that rehab prescription can be a source for ongoing information, maybe. I know in my area, one of the trauma centers have got a very elaborate, concise, you can identify the injuries and person dealing with it. I will ask you another question, and that I think is quite relevant in neuro rehab and spinal injury services. You had a fair number of patients with TBI with spinal cord injury. Now, you didn't mention whether they were moderate or severe, but you mentioned the frustration of the team due to lack of motivation and cognitive issues. Do you think the spinal injury centers are the right place to address rehabilitation in this cohort of patients?
Well, to clarify, these were not severely traumatic brain injury patients, but some of them had craniotomy and evacuation of clot or something like that, who presented reasonably well on our outreach assessments and interviews. So we decided to take them on because there is no structured traumatic brain injury. So patients with this, where would they go? Because there is significant neurological impairment. There are significant issues around the core injuries. And the traumatic brain injury units, even if they admit, they don't have long-term follow-up protocols in London, especially in my area where we cater in this part of the northwest London. So we do take this group of patients, and we do pretty well because we have got a group of psychologists and 2 psychiatric consultants. So we are pretty good. And then with this protocol of getting information, we also have decided to get the people trained into managing these patients. So extra training to psychologists to have more cognitive psychology input, to the doctors, to the nurses, in case if there's a challenging behavior or any issues related with the brain injury, then they can be reasonably managed on our unit. But the whole question is, who is going to manage them if we don't take them over? And that is just relevant to our region. I don't know about the other regions, but that's what that has helped actually this group of patients, because we have been able to manage them well. The main frustration was also after discharge, where they would go for traumatic brain injury follow-up. As I said, that there are not specific pathways for outpatient follow-ups, like say regional rehabilitation unit in Northwick Park. They would not have any pathway to see these patients in the long-term follow-up if they have a brain injury. So we decided to get them here, and then we try to provide maximum input we can as a team. But there is an ongoing learning process for all the doctors, the psychologists, nurses, and the therapists, how to manage not only cognitive, also the polytrauma, the limb trauma, pelvis trauma. Patient comes with fixators. Nobody have seen these patients before, and last 3 years we are taking now more polytrauma. So that's an ongoing learning. Yeah, thank you.
Okay, and well, I haven't. Oh, there is something else coming up. So Swaroop, let's see. Oh, I've lost it now. Okay, isn't there a scope to have an multidisciplinary clinic to streamline care all round? That's a suggestion from.
I completely agree. I completely agree with the multidisciplinary clinic, and we are thinking to outreach or do a kind of a satellite service to the trauma centers, so we can try these patients. We can provide earlier input by a consultant rather than just the outreach team. But again, the workforce requirement and the rehabilitations specialties, the least funded specialty, I would say. I always comment on this. I get criticized so many times, but that's what it is. So with more and more patients added on our list, and we hardly discharge anybody, it is just difficult to provide extensive services to other centers as well.
Okay, thank you very much, Manish. We will move on to our next speaker, who is Ming Chin. She's going to speak on the outcome of both conservative and surgically managed spinal ankylosing spondylitis fractures. Play, please.
Hello, my name is Ming Chin, and today I'm talking about the outcomes of both conservatively and surgically managed spinal ankylosing spondylitis fractures in our Scottish Spinal Injuries Unit. Ankylosing spondylitis is an autoimmune spondyloarthropathy mainly involving the spine and the SI joint. It has a prevalence of 0.5% and most commonly affects men in their 40s. There is an increased risk of chopstick fractures due to the long lever arm effect of the fused spine and osteoporosis from chronic inflammation. Patients with ankylosing spondylitis are 4 times more likely to sustain spinal fractures than those without. This study aims to describe our experience and outcomes in treating spinal fractures in patients with ankylosing spondylitis. We searched the Scottish PACS database for reports containing spinal fractures and ankylosing spondylitis between 2010 and 2018. We analysed 81 fractures from 71 different patients. We looked at skim and motor scores, admission and discharge Asia, length of stay, time to fusion, complications, and mortality. 73% of fractures were managed in the unit. The average age of patients was 68 years, with 2/3 being over 65. 87% of patients were male. 93% of injuries were due to falls, and 66% of all injuries were low velocity. This includes falls from a height of less than 2 meters. 45% of patients had delayed diagnosis of fractures, and this was mostly due to patients presenting late. 49% of all fractures were located in the C-spine, 42% in the T-spine, and 59% overall were located in the junctional regions between C6 and T2 and T11 and L2. 63 patients were treated conservatively, of which 5 eventually underwent surgery. 41% were managed in a halo, 34% in a brace, and the rest with bed rest. The average duration of treatment for the conservative group was 125.9 days. 18 patients were operated on. 89% had posterior fixation at an average of 6 levels, and this was carried out on average 12 days after admission. The average length of stay was 82.9 days. 60% of patients had no neurological deficit. 1 patient deteriorated on discharge, but 4 patients improved. Not all fractures were admitted to the spinal unit. Out of 52 patients admitted, 19 patients had motor scores documented. Average improvement was 8.1 points, which plateaued around 150 days. This small improvement likely represents the fact that patients already had quite a good motor baseline on admission. 27 patients had skim scores, which are a measure of function, documented on admission. Average improvement was 50 points from admission to discharge, plateauing around 200 days. We defined fusion as bony bridging on CT or X-ray. Where this was not available, the absence of pain at the fracture site or deteriorating deformity or neurology at follow-up was accepted. The average time to fusion was 193.7 days. 59% were fused by 180 days, and there was no statistical difference in time to fusion between the conservative and surgery groups. The majority of complications were related to chest and urine infections. 2 patients had post-surgical non-union, and 1 was reoperated on, the other was conservatively managed. 8 patients died within 30 days of admission, all due to pneumonia. This gave us a 30-day mortality of 10.5%. Delayed diagnosis of ankylosing spondylitis fractures is not new. This is likely due to a combination of chronic pain and low-velocity injuries, making it difficult for patients to recognize when a significant injury has occurred. Fractures are also often missed on plain radiographs. Our unit favors a more conservative approach as our patients are older and more comorbid, so they are less fit for surgery. This is one of the largest series looking at the outcomes of patients with ankylosing spondylitis and spinal fractures, and it showed that there are similar outcomes in the conservative versus surgical groups, which supports conservative treatment in our cohort of older and frailer patients. Thank you very much for listening.
Joy, she's not there.
Yeah, Joy, you've got about 2 minutes for questions.
Okay, no, thank you. Is she in? I can't.
Hi, can you hear me?
Yes.
Oh, yeah, great. Thank you very much. A lovely presentation. We do have one question.
Okay.
From Adil Ahmed. Great talk. How were the conservative patients managed, i.e. collar protocols, removal times? That's one of the questions I was going to ask too. So what do you define conservative management?
Okay. So conservative management was anything that wasn't explicitly surgical. So we had things like halo application that was conservative. We had braces as well. We had bed rest, which was quite common in our unit as well, bed rest. So these were some of our conservative managements. I'm not entirely sure on the exact protocols and removal times. Obviously that depends on what modality we're using, so they would be different for each type.
Okay. I will just ask another question. Did you actually differentiate between the fractures through the disc as opposed to fractures through the vertebral body?
Yeah, we actually did. We did look at the difference between disc and vertebral body fractures. If you hold on a second, I've got more data here. I'll have a wee look because I'm sure we did.
Okay. And a final question from Michael Grevitt. Your study is extraordinary in having so many fractures with no neurodeficit.
Mm-hmm.
Are you able to comment on this? Would your death rates from pneumonia be less with more surgery?
So I'll answer the second question first because I think that's easier. I think yes, because we know that there are problems with patients being incumbent when they have conservative management, such as bed rest. They're not able to mobilize as well. And if you fix them, obviously we can try and get them up earlier, and that would probably reduce the rate of pneumonia and things like pulmonary embolism. So I think that definitely would have played a difference. In terms of why we have so many fractures with no neurodeficit, I'm not entirely sure, but I do know that most of our patients they had low velocity falls, so the injury wasn't it wasn't very traumatic in the way. We only had 5.6% of our patients who had concomitant traumatic injuries and polytrauma. So that probably reflects why most of our patients actually did very well neurologically. Actually, they just probably fell from a small height and didn't actually have big trauma.
Excellent. Thank you very much for that, Ming. I'm afraid, Joy, we're going to have to call this session to an end. And he's switched off. So thank you very much all for your presentations and for your questions and for your interest. We'll be closing this session now and moving on to the endoscopy session. Thank you very much.
Thank you.